welcome to my Sunday show. Today's guest is Professor Karol Sikora. Welcome, Karol. And I was interviewing Professor Robert Thomas a couple of weeks ago. When I said you were next on, he said, "Oh, I love that man." He said, "What hasn't he done?" Which I thought was a good line. Well, I mean, I've got here that you went to Cambridge. Never mind, we won't hold that against you. Then you were at Stanford and you got your doctorate there. And then you went to Imperial Cancer Research Fund, which became, didn't it become Cancer Research in the end?
Exactly.
And then you were chief of the cancer program at the World Health Organization. I think you have on that. And I know you did some helpful work with Penny Bron just to help them out a couple of times. But now, most importantly, we're going to talk a lot about this today. You're founder of Rutherford Health. That started in 2015. So I'm sure there'll be lots of questions on that. But what I was going to say was the first time I remember us meeting was at a cancer prevention conference. I think it was in 2004. We had lots of people talking there and a room full opposite the Houses of Parliament. And we had just done, Cancer Research had just done some, Cancer Active had just done some research on cancer prevention. And while 68% of people knew how to prevent a heart attack with some reason, and about 66% of people knew how to prevent diabetes, only 4% of people in 2004 had a clue what to do to prevent cancer in any shape or form. Do you think it's changed?
Probably not much, although Cancer Active has been very active at getting the message over. The real problem with cancer prevention is targeting it to the right people. And there's not that much that cancer prevention involves. Obviously, cigarette smoking, diet, general nutrition, general health, exercise, and I guess a positive attitude to life. Just keep moving and doing things. And that actually, amazingly, will reduce your risk of cancer. You know, there's no magic pill that will prevent cancer. And we'll get to this later. There's no sort of serum factor you can measure to measure risk and then see it go down. You know, with heart attacks, if you've got a high cholesterol, you can measure the cholesterol, you can take a statin, and then you measure it again after a couple of months, and it goes down. So you can follow the level of risk you have. With cancer, there's nothing quite like that. There's nothing to measure. But I think the message is there. The difficulty is actually putting it into practice. And what Rob Thomas was talking about 2 weeks ago in your last podcast is quite sensible. He's into holistic lifestyle, and that's what it is all about for cancer. And it's not screening or doing fancy x-rays or doing PSAs. It's more about your general lifestyle and how you can be healthy. And the good news is what's good for cancer is also good to prevent heart attacks. So you're getting
that's right.
Those compartments. I know. If you want longevity, you know, the average age of life in Britain is 83 years now. If you both men and women 2 years longer, men 2 years shorter, so average is 83. Now, the one observation I've got, if you go to a care home where you've got lots of people, obviously there's more women than men because the men have passed before the women, but also there are almost no fat people. It's quite amazing. If you look at a care home, there's all these thin ladies and they're running around, scurrying around. And why is that? Because they lived long, because they've not had cancer or heart disease, because they stayed thin and they're on a reasonable diet. It's an obvious observation to follow. And I think Cancer Active has your magazine is lovely, and it shows in a pictorial way what you can do.
When we can get it back in, we're praying we can get it back in within the next year, because we were at 140 hospitals and cancer centres and libraries in Britain, but it just suddenly went with COVID. One of the things I read when, my daughter obviously had a brain tumour, and one of the things I read at the outset was a World Health Organization report on the causes of cancer, and it was written by a chap called Karol Sikora. And I always remember that about you. And it must be very hard, because you kind of have to put the causes down with a percentage. And I remember we interviewed Dr. Henry Friedman at Duke's in Carolina after we were 10 years old. And he said, you know, at the end of the day, there's no one cause of cancer and there's no one drug ever going to fix it. And it would be naive to believe it was. So how do you decide, when you're writing a report like that, how do you decide what goes in it and what percentages they all have?
It's very difficult. What you can do is take the world literature and look at all the studies that correlate between a certain diet, for example, vitamin levels, smoking history, and the incidence of relevant cancers. And most of the carcinogens that we're all exposed to, we can't avoid it, cause a whole range of cancers. So, for example, cigarette smoking is not just lung cancer. There are other cancers, esophagus, head and neck cancer, even pancreatic cancer is elevated with smoking, quite why we don't understand. And then putting it together. But you're right, the biggest difficulty is assigning a number. How important is it? The other thing, it's not just what's out there, what's attacking us, so there's the external carcinogens, if you like. It's how we, the body, the genetics of an individual deal with those toxic chemicals out there. And some people deal with it much better than others. Some of it's racial, so different racial populations are going to have different ways of handling carcinogens. And in other cases, it's age-related. I mean, the thing about cancer, if we all live to be 200, just imagine, it's likely we'd all get cancer. That's the nature of the disease. It's a natural breakdown of cellular control that's sort of inevitable if you let it go on and on and on. The fact that Stone Age man died at the age of about 35, long enough to reproduce, have a family, and then he was written out to genetic history. He wasn't needed anymore. And the women the same. So the average age of death was about 35. With modern medicine, that's come up to 83, which is great. But it means that most cancers are when you get to 50 or more, because when evolution for humans was happening, cancer wasn't important because it was disease after you would have died normally after 35. So it really didn't count for human evolution. Now it does. And the difficulty is what to do about it. So all those influencers out there, and I don't mean on TikTok or something, but influencers of cancer risk are so difficult to measure. And
yeah, I remember actually at the speech, I stood up in the morning and I said, just as an amateur in all this, I feel that, let's call them parasites, pathogens, are involved in about 70% of cancer. And there's a bit of tittering and laughter around the room. But in fact, in the afternoon, Professor Angus Dalgleish stood up and said exactly the same figure. I mean, I've just done a thing on liver fluke and bile duct cancer because I had a lady who had bile duct cancer in India a couple of years ago, and daughter and son came to me. And after about 10 minutes, I said, you know, your mum's got a parasite. It's got to be a parasite. And they said, oh, yeah, everybody has. We all eat the fish from the river. And when I was researching liver fluke, Thailand's the worst place in the world. We're up in northeast on the Cambodian border. Everybody eats their prawns raw and their fish raw, and they've all got parasites. So
I mean, it's a fascinating story, Chris.
How would you deal with parasites? Because people now are coming on holiday to Thailand, and I've had 4 people with bile duct cancer in the last year. They've all been to Thailand in the last 25 years.
No, it's a fascinating story. WHO, when I was there, actually had a project up in Laos on the Mekong River where the fish live. And it's not the fish that caused the problem, it's a parasite, as you say, that lives on the fish. And it's very cheap. So the poor fishermen, that's all they've got. They have no money to go and buy something else. So it's a great example of disrupting an economic food chain. So that's all they have to do. To change their diet costs money. If you're going to provide them with fish from the sea, that's got to be transported up. That means they can no longer catch it. The way it was done, families would just go fishing with nets. They just lower the net in the Mekong, out come up, that was your dinner for the night. And then you get a few potatoes or other vegetables from the garden, and that's how it was done. But cholangiocarcinoma, as it's called, bile duct cancer and bile gallbladder cancer, is the commonest cancer in that part of northern Thailand and Laos. In Laos, there wasn't a single oncologist, so there's no treatment other than palliative care. And the difference in palliative care in somewhere like that is it's beautiful. It's family oriented. The family all gather around and the children are playing, just as you can hear here today on a Sunday. In England, the grandchildren are here. And death is accepted as a normal part of life. In Western culture, we send people off to die, or we make a big deal about it. Whereas there, that's just part of life.
I'm married to a Thai lady who just says, I don't want to leave the world yet. That's her view.
That's my view too, and it's your view.
Leaving the world at some point. I don't want to do it yet. I've got a question from a number of our viewers. Mary Simpson asks, why does cancer research insist that stress does not cause cancer?
It's a very difficult question. And the reason is, how do you measure stress? And that's the answer I give. It's so difficult to measure. And, that doesn't mean we shouldn't try, but what's stressful to one person may not be stressful to other people. So doing this video, for example, doing this podcast, to some people will be very stressful. Being interviewed by Chris Woollams, for goodness sake, this is terribly stressful. But I find it quite relaxing and quite enjoyable to talk to you on a Sunday morning. And so everyone is different. So that's the first problem. The second problem is stress changes once you get used to something. So the first time you do something, it may be stressful, but after 10 times it becomes easy and you wondered what the fuss was about.
But
so
we do know, don't we, that there are certain factors that turn on COX-2, which causes inflammation all over the body. And one of those is stress and another one is fear. So there are definite biochemical factors.
There are definite loops and mechanisms in there. So it's not a crazy idea that stress causes cancer.
What about the idea, Melanie Wright asked, why do cancer research and the WHO, World Health Organization, believe environmental toxins are only a small factor in cancer?
Again, it's a measurement problem. It's difficult to measure. And it's difficult to measure how, if they're there, why aren't we all getting cancer? That's the problem.
Well, a lot of people would argue part of the increase in cancer is to do with environmental toxins, that they are there.
And there's no doubt that cancer is on the increase, and it's more than just people getting older. The biggest reason for cancer in different countries for different incidences is mainly age. So poorer countries, less old people, less cancer. But that's not all. There are other factors. So industrial places, Bangladesh, for example, has overall a low incidence, but in the inner city areas where there are factories and pollution, it's much higher. So there's no doubt environment plays. A clean environment, you can imagine the green fields and the pleasant, like the plants behind you in the conservatory.
I had a chap come to me and he was, Jeff Boycott sent him to me, and he was actually chief executive of cricket at Lords. And I walked into his room and all the windows were open and big windows overlooking the pitch. And I said, where's your aircon? He said, we don't have it. This is Lords. And I said, how often you spray the pitch? And he said, 3 times a week. And I said, what, every week? And he had multiple myeloma.
Right. Well,
farmers get more of and so on. About 8% of myelomas farmers and so on. So that means something. I think there can be connections, but I come back to my view, which is that it's never one thing. I think you build up a body over a 10-year period, a body that's conducive to cancer, and something maybe tips you over. But it's usually lots of things. I've got a doctor's question next. Dr. Michael Barry says, we're changing the subject slightly. The NHS has highly dedicated, caring and clever people working for it, but a poor organizational system. What can be done to make it better?
I've been a consultant in the NHS for 40 years now this year, and I've seen so many changes of management. I think there have been 17 titanic moments when they rearranged the deck chairs. The boat still hits the iceberg, and the boat is hitting the iceberg, not because of money, but because of poor organization. And when you actually look at it, if you were designing from scratch on a sheet of paper to get the best healthcare system in the world, you wouldn't have the system we have, which has gatekeepers, that's your GP, that you could never get to see. You know, getting to see a GP in this country can take 6 weeks and a lot of phone calls. And that's an exaggeration, but it's sort of the first problem. The second problem is the complete separation of social care, primary care, and the hospital service. So if you go around Hammersmith Hospital this morning, Sunday morning, if we pitched up there on the cancer ward, I bet we could find 20% of the patients in there, and there are about 130 beds overall. About 20% could actually go home now, but because they've got no one to look after them, they're stuck in hospital. It's nothing to do with a medical reason. It's purely a social reason. And
did I read somewhere you had words with Mr. Obama?
I did.
I've done my
You have. I've been thought of as a critic of the NHS because I said something at a meeting that the NHS was the last bastion of communism in Europe. That is not a good thing to say. People didn't like me saying that.
Oh, well, you've got to be controversial.
But it's exactly. And the real problem is it can't carry on doing everything for everyone. It's an illusion that it can. And once you realize that, we've got to focus it better. And there's all sorts of ideas out there to try and make it much more focused. Nothing wrong with the staff, the technical side is fine. Doctors, nurses, physiotherapists, all the professions in it are just fine. Training is fantastic. It's better than anywhere in the world, I would say, in Britain. What's wrong is the delivery and how it's organized. And it's not even underfunded. It's a concept that you just throw another 10 billion, the budget's 120 billion, so put another 10 billion in and everything will be fine. And of course, I hate talking about COVID, but that really has been a blast.
Well, that's the next question David King asked. What on earth happened to cancer treatment during COVID? How are they going to catch up?
We have caught up sort of on diagnosis, but there's still a lot of hidden patients that haven't come forward. I mean, really 3 reasons. First of all, the patients themselves got scared stiff and avoided all medical care. They just put up with their symptoms. Secondly, they couldn't get access to the GP. And then thirdly, the GP couldn't get them to get x-rays. And, you know, cancer's diagnosed, as you know, in 2 ways. One, by taking a biopsy of the cancer and sending it to a lab. And secondly, by imaging to see where the cancer's got to. If you can't get a biopsy or you can't get an image, you can't diagnose cancer. So Cancer Research UK estimated that something like 40,000 people didn't get diagnosed in 2020. Normally, there are 350,000 patients a year in Britain that get cancer. So, and it's the same in Australia, the same round, always pro rata for the population. So you can work out what it is. The problem is that if the patients aren't being diagnosed, the cancer rate falls. And you think, oh, that's good. There's no queue in the radiotherapy. There's no queue for and of course, what's happened, the queue's been pushed right to the back, to the beginning of the whole process. And we know that if you don't get diagnosed at stage 1, there are 4 common cancers: lung, breast, colon, and prostate. In all of them, stage 1 cancer, when it's confined to the organ, no spread anywhere, is 90% chance of cure. Whatever you do, it's 90%. And the cure is usually simple. It's often simple surgery, simple radiotherapy, simple chemotherapy.
Can I pick you up? Do you mean cure, or do you mean 5 or 10 years survival?
5 or 10 years survival. But if you're, but most patients, if you live 5 years, you're going to live a normal lifespan, which is so. But if it spreads to say stage 3, you go from 90% down to 20%. That's a huge jump, which means that any delay in that early phase is really bad. The question is, how big a delay can you have? And there's an interesting paper in the Lancet at the peak of the pandemic that really showed that almost certainly a delay of 3 months in most cancers was very significant, in that you shifted the stage, you upstaged the patient from 1 to 2, and sometimes from 1 to 3. And if that happened, your survival was adversely affected. And you know, it's a curious business that we gave up treating cancer patients, not because we didn't have the downstream process available, treatment. It was patients weren't coming through. And that's a fault, and that should never have happened, Chris. And it happened all over the world.
So how are you going to play catch up?
That's a problem. So we've got 5 million people on a waiting list for an operation. And most of those haven't got cancer, I'm glad to say. But in there will be some with cancer that don't know it. And to sort it out, it's all done at a local level. What people have to realize is that they have to be a little bit more. Everyone thinks the NHS is such a wonderful system, especially now. The George Medal was given to it by the Queen the other day. The most important thing, if you have symptoms that are progressive, they're getting worse, week on week, they're getting worse, pick up a phone, do something about it. It's not going to look after you in the way you think it's going to look after you. You have to be a bit more proactive and get out there. And I think that's the one thing we don't do in this country well enough, which our European friends do.
Well, I think to patients, though, a lot of patients are frightened. I mean, if they want to be proactive, and I mean, most of the people who ever come near me do want to be proactive, they find actually most oncologists put them down.
Yeah.
And that's, I mean, I think it's, when you want people to be proactive, I think it's, again, something to sort out in the NHS system if you want people to really be proactive.
People say, well, maybe it's because we don't pay for it. I don't think that's the answer. I think British people, the way they handle health is not being pushy with it. And some are now. And, it's interesting to look at my kids who are in their 30s and how they deal with it. They deal with it with their smartphone. Health is for the smartphones. And they're right. I can't work the smartphone properly. I mean, I can make a phone call, but, the sophistication with which my daughter can use it to do all sorts of things with one finger or the thumbs is quite unique. And I think that's the problem.
Yeah. So, you're not going to get away with this, because I get asked a question always, and you're going to get asked it. Sally Griffiths asks, do you think people with cancer should be vaccinated against COVID? And would your answer differ if the patient were under 50 or over 50? I think it's a good part of the question.
Sorry, the dog just came in.
Don't worry.
Okay. No, good. Okay.
Stuff for little children and animals.
Yes. The relationship between the effectiveness of the vaccine and cancer is really unknown. We just don't know. And different patients, different things. So if we take an extreme, a patient that is fully immunosuppressed on very high dose of chemotherapy, say for breast cancer or for lung cancer, it's likely that the immune response will be weak, but it's probably still worth doing. At the other end, you've got someone on mild hormone treatment for breast cancer, then it's not going to be a matter. You'll get a full immune response. So it's almost certainly worth doing, because what you don't want is to get COVID at any point. So you may as well have the vaccine. That's what I've been telling my patients.
Well, Martin Beer asks, he says, how protected from COVID are people with B-cell lymphoma who have had chemo? And he goes on about the cycles he had, and both vaccine shots, and what additional precautions should people use?
The only precaution you can take is to isolate yourself, which is a bit sad. I mean, I've tried to persuade people just to forget it. I mean, it's difficult to forget, but get the vaccine and then just go out and about, and just be careful. Don't go to a football match. Don't go to the World Cup tonight. The European.
£57,000 a ticket, I read. So.
Yeah, exactly. Do not go.
So dare I ask, which vaccine did you personally have?
Well, I took what I was offered, which is the Pfizer vaccine, and we were very early. The healthcare workers got it very early in the UK.
Rob Thomas did as well.
Yeah, and I went. It was great. I'm 8 o'clock on a Tuesday morning at Hammersmith Hospital. We were all lined up. They did it by departments. So all the oncologists were there eating buns, and we found there was a bun shop open, a coffee shop, having coffee, and thing, waiting for the jab. And it was like, and then we went back 8 weeks later for the same thing. It was, and we're tested. The other thing is we're tested twice a week with a lateral flow test, and then once a month with a PCR test. So there's not much more you can do except to forget, you know, that's, and then the dreadful mask wearing, which is sort of, everyone's got bored with, even in hospitals, people.
All right, let's move on a little bit because again, something I picked up from one of your tweets, but I've been championing this sort of thing for quite a while. Right since I think I wrote my first volume of Everything You Need to Know to Help You Beat Cancer, which was something like 18 years ago, I've been talking about if only we could test people early, then actually we could use a different range of less invasive treatments. Maybe I'm right, maybe I'm wrong. And first of all, there was the oncoimmune test that I covered from Dana Faber and the Mayo Clinic. But recently, we've got these this blood test that's being rolled out in Britain. 165,000 people are being given a blood test right now. It's called the Gallieri test, isn't it, by Grail?
Yeah.
And you know, they're not going to stop. This isn't a pilot test. They're going to keep going. And in all the research I read at Dana Faber and the other place, it was 99% accurate, only 0.7% false positive. Surely this is a game changer, which is what I said in the article.
It sounds like it, and it may be, but there are drawbacks as well, Chris. As always, it looks good. It's called the Gallery test, and it is from a biotech company in California called Grail. Not the Holy Grail, but it's spelt the same way as that Grail. And the test picks up circulating DNA. It's just a blood sample that's sent off to the lab. They pick up circulating fragments of DNA that come from any wayward cells, cancer cells. And they recognize it because they have different patterns of what's called methylation. The DNA is activated.
Yep.
So you look for that. And it works for all cancers because all cancers have the same activated pathways for DNA. And in some cases, you can actually determine which cancer it may be. The weakness with all these things is, first of all, the cost. That Grail is selling this test in the States for $950, so that's quite a lot of money. And if you have to have it once a year, otherwise it's no good because you have to, it's a test to screen for cancer, if you like. So that's a significant cost. The second weakness is there are bound to be false positives. There are bound to be people that have some circulating abnormality that turn out to be not having cancer. That's going to cost a lot for the patient in terms of time and effort to screen. So they're going to have an MRI, they're going to have CT scans, all the other blood tests, and that has a cost, and it has a psychological cost. You know, one of the things we forget in the breast screening program is the psychological trauma the women go through if they're recalled for another mammogram. It's something you shouldn't discount because often you know, it takes 2 or 3 weeks to get them back, and they live bad. They can't sleep for 2 or 3 weeks because of it. So this could cause problems. But the most important thing, Chris, at the moment, they're going to put it into the NHS. 140,000 people will be offered it for free. I mean, no one will be paying. NHS won't be paying. It's a sort of way of getting the company to assess its own product. And it's certainly worth doing that and then looking at the data.
Well,
the data
they've got the NHS have got a goal, which I think is excellent, of actually trying to get 3/4 of people in Britain with cancer diagnosed at stage 1. Now, yes. I don't know whether that you're much nearer the coalface than I am. I don't know whether you would say that's possible, but they say half of people are diagnosed stage 1 and 2 at the moment, and that seems to be where the drawbridge goes down: 1 and 2 versus 3 and 4. And if you can actually get far more people diagnosed at stage 1, even if it costs the best part of £1,000 a year to do a test, how much are you going to save on chemo? How much are you going to save on right. everything else? I mean, it's a fortune, isn't it?
It is. I mean, if you look at the health economic overall picture, which you have to do, it could be fantastic. The drawback is, as I say, non-specific positives. In other words, the test comes back positive, but in fact, it's negative and there's no cancer. And yet to prove that, you've got to do a whole load of tests. You worry the patient and their families, and you're no further forward. And, you know, the problem, it's going to be a GP-led test. So the GPs are going to have to do a lot of explanation if they get a result that comes back positive. And we're going to have algorithms, protocols to make sure the patient gets the right set of tests afterwards. And that's one of the weaknesses. One of the reasons Britain's a bit behind Europe in survival for cancer is not because we're not treating it properly. It's simply we're diagnosing it later because of the sluggishness of the whole system. It's just too slow.
I am in one of the volumes. We're up to about edition 7 now. Just so I'm supposed to be writing it this week. In one of the things I was talking about how if you caught something early, and I quoted some research done in the Karolinska. They actually did 3 clinical trials in the Karolinska about 6 years ago. And they were taking women with a very small lump in their breasts and sticking a pin either side and passing a current across. I think it was a bit stronger than a pin. And they were passing a current across. And across 3 trials and 90 women, only 1 lady had to come back and have it done a second time. And literally there was 100% success. And they were talking about having it done during the lunch hour. And what occurred to me, now it's been dropped. It became the nanoknife. The nanoknife was already patented in America. But it just became clear to me that if you could catch these things when they're at the small lump stage, you could use these more, if you like, modern technologies. But I know that this is a long question here, but I know that, you know, Mark Emberton, for example, has had terrible problems with HIFU and getting the research done and so on. And, you know, we've, Edward Lean, I think it is, has had terrible problems with nanoknife and so on. I'm not saying they're right or wrong or anything like that, but you've got ablation, cryoablation, nanoknife and HIFU, whatever. I had to explain to a lady in Portsmouth, I think she was, about ablation and cryoablation, who went then back to her doctor, her oncologist, and she explained it to him. He said, "Oh, don't do that here." And she went off and found another hospital who would do it for her.
Right. I mean, ultimately, the obvious way to treat cancer is, first of all, to diagnose it early, to make sure you know exactly where it is before it's spread anywhere to lymph nodes or around the body. So you know it's just located, say, a 0.5 centimeter lump. That's it. So you have to remove that or destroy it. It doesn't matter how you do it, with electric currents, electrolysis, as in the Karolinska. Mark Emberton with his HIFU at University College. That's a good way with ultrasound, focused ultrasound at high energy. That's what HIFU stands for. And radiation, whatever, anything that destroys the lump, or classical surgery, just flip it out. And the chances of success, if it really is localized, are nearly 100%.
Yeah.
And so a test that comes along that tells you this patient's got cancer, and then the right imaging to show you where the cancer is, and provided it's early, that would really lead to a revolution in cancer treatment. And you're right, that's how it will go.
Yeah, that's what I was hoping in my notes. Right, I actually got attacked by Cancer Research. I remember for praising, they have a blogger there who's in with the skeptics, for actually praising this blood test across Britain, because I thought it was a really good idea. Cancer Research didn't at the start. They thought it was too many problems. But now we go on to something very dear to your heart, which is proton beam therapy. I got hit again by the Cancer Research blogger, right? And the reason was I must have written up proton beam therapy in about 2011, 2012. And at almost the same time, they'd got, is it the CyberKnife? Cancer Research had been involved in paying for a couple of CyberKnives, one up in Manchester and one down in South, I presume Royal Marsden or something, which goes round your head. And of course, I was terribly interested because of Catherine's brain tumor. And I looked into it a lot. And MD Anderson, as far as I could see, had developed it in 2005. By the time I wrote it up, had done 15,000 studies on it. And, you know, all the blogger from Cancer Research could say was, well, proton beams may be coming to Britain, but there's no research on it. Okay, tell me all. Tell me about proton beam. Tell me, why is there this resistance?
So radiotherapy destroys cancer cells, and what's happened over since I've been in the business, it's got very precise. We can precisely deliver radiation within millimeter accuracy, and that's conventional radiation. Proton beam is also radiation, works in the same biological mechanisms as conventional radiation, but it has different characteristics in how it deposits the energy. So protons stop. When you fire, if I fired a proton beam at you, there'd be nothing coming out into the sofa behind you. If I fired a conventional beam, about 2/3 of the energy would hit the sofa, would go through your curtains, and whatever's beyond there, I can't see what's beyond the curtains, but it would go right out there.
The swimming pool, actually.
Yeah, it would go into your swimming pool. And so protons stop, which means that tissues behind the target for the protons don't get irradiated. So in certain parts of the body, for certain types of cancer, that is a profound advantage, because the art of good radiotherapy is to target the tumor, highest dose as possible, and normal tissue, especially critical normal tissue, the brain, the eyes, the spinal cord, the lung, the heart, everywhere in the body there are critical tissues, to give those tissues as little radiation as possible. And we can use all sorts of tricks with the computer to maximize it, but having protons allows you a little additional scope for maximizing the precision. And you know, it's not for a single tumor type, it's really for all tumor types in different anatomical structures. So brain is,
I mean, it works. That's the other big point.
Yeah, it does work.
The first person, this will interest you. The first person I ever came in contact with, it was a chap who was a zillionaire in, I think, in the Bahamas. And I spotted that all his scores were going up early, and we talked about what he could have done. And he ended up going off for proton beam therapy in America for his prostate. And that's 11 years ago. And he hasn't got a touch of it now.
Now we created the Rutherford to basically build proton sensors. We do other things as well. And we built 4 of them in the UK. And we've treated over 100 prostate patients. They've all done well. I mean, it's just amazing. No symptoms at all. And I think the difficulty is, can you get it on the NHS? Yes, you can at Christie, but it's for a very limited range of indications, very rare types of cancer, mainly children's cancers. And, you know, the rigid age cutoff, 25. Nowhere else in the NHS do we have a cutoff at 25 years. If you're older than that, you don't get the treatment.
Well, you know, that's really interesting, because, I mean, I got involved in Aisha King, and we talked about this.
Yes, I know.
And it was a young boy, for our listeners, a young boy, I think of about 11, maybe not that old. And he had a form of a brain tumor, which is eminently treatable by proton beam, got kidnapped by his parents, got caught. And in the end, the judge said, yes, you can go to that proton beam center, not for 2 hours, only 2 hours from London. Yeah. It's in Prague. Yeah. And off he went to do that. But let's just talk about brain tumors for a minute, because it seems to be brain tumors with a lot of kids getting brain tumors. I mean, I did the conference for kids with cancer, and a lot of children get it. Surely, tell people listening why it works for some and not for others.
Okay. So there are several reasons. I mean, if you have a small tumor, say on one side of the brain, especially if it's near critical structures, say the optic, the nerves going into the eye, they're called the optic chiasm when they cross over. That's a critical position. Now, protons can avoid lots of the other side of the brain. It can avoid the eye, whereas conventional radiation, it would be difficult to avoid completely all these other structures. So you get better precision with protons there. If the tumors spread right round the brain, and this is something people get confused with, it's often called grade 4 glioma or glioblastoma. If it's spread right round, unfortunately, there's nothing you can do, and the prognosis is very poor. One thing doctors don't like telling patients, or indeed families of patients, is one of the reasons why we can't use protons or it's not worth it, is you're not going to live long enough to get the toxicity, the unpleasant side effects of conventional radiation. So you may as well have conventional because we can do it locally. I mean, in Britain, there are now 5 active proton centers, but if you don't live in that town, you're going to have to travel miles every day or stay in a hotel. And if the prognosis is really poor, it's probably not worth doing. So there are all these sort of factors. But protons are here, and the combination with computers and planning allows us to choose it for the right patient.
But the budget is there in the NHS, isn't it? And always has been. Because I know you're saying, but it's only for people up to 25, the way the NHS is doing it now. But I had 6 years ago, I had a man in the West Country with prostate cancer, probably had also very good connections. He got sent to Prague.
I know. And we've had NHS patients sent to us at the Rutherford, and you just wonder how the selection's been made. And it's back to what we were saying very early on in the NHS. It's the structure's such that if you're pushy about yourself in a polite, non-aggressive way, often you can get surprising things that you wouldn't think were possible.
Yeah.
And I think, you know, the whole proton thing, it's like a rationing exercise. And, you know, if the protons will come down in price, and I could see a day, not far, maybe 10 years, when every single radiotherapy department of any size in a region, the UK and indeed globally, will have a proton machine. Why not? And ultimately, we're going to be taken, radiotherapy is going to be taken over by artificial intelligence, because the computer can do everything much better than the human brain when there are many, many factors involved. What the human is needed to do is to explain to the patient the decisions and to involve them in the options, because all the time there are options in cancer treatment, as you know. And understanding the risks and benefits and which way to go in an individual, it involves personalities. One of the problems, Chris, that you'd be interested in is if you look at 100 oncologists, they have different personalities, and some are more aggressive, some are very timid about what they do. But it's not how the oncologist feels about it is sort of irrelevant, I always think. It's how the patient feels, their customer. You know, and they've got to match. Now, in some cases, if you have unlimited resources, you can match your oncologist just by shopping around, finding one that seems to talk sense and you like the idea. But most people are fairly, you know, receptive in the NHS. They don't do that. So they don't go shopping. They just accept what they're offered, and it's free, and that's great. Those with many resources might not do that. They might go looking for someone and say, I need a second opinion here and there. And in many cases, it will make no difference, but in some, it will make a difference. And that's one of the problems in cancer.
I always tell patients not to actually express it in a way that challenges their oncologist.
That's a very polite way of doing it, but you're right.
Well, I was in advertising, and if you went down to the creative department and said, I've got this great idea, it would never run. But if you went down and cajoled them into thinking that maybe there was an idea here somewhere, then they were, you were right.
No, it's very true. And I think we're seeing much more questioning than we ever did in medicine. You know, when I began, we didn't tell people, it began in oncology, we didn't tell people they had cancer. So it's very easy. It's like veterinary medicine. You just say, you've got a cyst, you've got an infection, we'll give you some pills, give you some injections that will go away. So how easy is that as a communication system?
You're still on your PPG. I've got a lady here, Joan Levy. She's had radiotherapy as a Hodgkin's survivor who has late effects from radiation treatment in 1979. Is there such a thing as a survivorship oncologist for appropriate, optimal monitoring and follow-up care for cancer survivors?
No, not that I know of. I mean, only your own oncologist. What we've done in the NHS, unfortunately, and again, it's a cost cutting, is stop follow-up at defined periods. So for Hodgkin, defined periods, 5 years. After 5 years, follow-up stops. You're referred back to your GP. And if you need, you're not even given a number to phone if you want to go back to the hospital. They've had nothing to do with you. That's it, you're out. And I think that's terribly sad, because as long as there's a lifeline, even if it's just a phone number, even if it's not a consultant, it's some other person, you feel that someone's caring for you, someone's looking after you. But to be just cast loose is dreadful. But my advice to her would be to go back to your original advice, say you'd like to have a consultation, and why not?
Now, the next bit, I think, takes me really to what I'm very concerned about with radiotherapy, that I don't doubt for one moment it's improved, it's very accurate and everything else, but as you say, it's going to hit my swimming pool and the curtains. This continuation, the damage before and the damage after the tumor. So Rita Morris, I had radiotherapy to my left breast 19 years ago. Now it's given me lung cancer. Is there anything I can do about it?
Well, you can have the lung cancer treated, and we don't have details of such. So that's, and she's right. Second cancers at the site of radiation is a risk. It's relatively rare, less than 1% of all patients having radiotherapy, but it's significant, and therefore making sure we're more precise. And over the last 17 years, we've got much better at being precise on the breast area, so we would irradiate less lung. And there's no doubt they're related, the radiation and the lung cancer.
When women tell me they're going to have radiotherapy for their breasts, I always say, look, just do yourself a favor and draw a little picture of the body and put your breasts on it and put your heart where it's supposed to be, and go to them and say, now, please show me exactly with this pencil where it's going.
And missing the heart, yeah.
Because, you know, I've had women who said, well, the oncologist told me it's only just going to nick my lung. You know, right. This, you know, you can do breathing exercises. And I got asked by RAGE, Radiotherapy Action Group, I can never remember what the last one's for, Exposure, that's right, to come and speak a couple of times. And I saw your name on there, actually. You've done some things for them. But I mean, they were quoting a few years back, 25% of women had some damage from their radiotherapy. Yeah.
And again, that was older techniques. It doesn't happen now. But you know what was happening, there were one or two hospitals, the brachial plexus, which is just under the shoulder, below the clavicle, underneath the clavicle, the bone that goes across the top of the chest, was getting radiated to a high dose with the breast. And this resulted in neuropathy, the nerve damage. I saw quite a few of these women, complete paralysis of the arm. It was horrible. I mean, really a useless arm. And a famous lady called Lady Ironside, who was married to Lord Ironside, hereditary peer, sued, and she lost, sadly. She sued the Royal Marsden, where she'd been treated 10 years previously. And there was a big legal case, and I remember seeing all the charts that were produced at the court, and sadly she lost, and that was it, really. And but it doesn't happen now, that's the only thing.
Do you think there's a reticence to use by oncologists, a reticence to use proton beam? You know, is there a reticence because they think their radiotherapies improve so much, or is it to do with money, or what is it?
It's to do with money and bureaucracy. To, you know, use your own radiotherapy machine costs you nothing. It costs you no paperwork. To try and refer a patient either for NHS radiotherapy or even for private radiotherapy with protons, you've got to fill in forms, you've got to do things, and there is a sort of inertness in the whole thing. Now, if the patient asks, that's different. You do it. But is the onus on you to tell the patient about something that's more difficult to arrange? And, you know, we're still, within the NHS, we still have a fairly negative attitude to cancer, more negative than the rest of Europe, for example. It always surprises the Italians. You know, you think Italy's full of chaos, you know, you look at the roads and everything, and yet you look at their oncology, it's fantastic. It's really well organized. Even in small country hospitals, it's usually a visiting oncologist, and it's well set up to the cancer center regionally and so on. So it's a model. And
what would you tell our listeners? What are the best cancers for using proton beam rather than radiotherapy?
Right.
Are there
so
ones?
Yeah, there are. Prostate's obviously one, but lung, brain, head and neck cancers, left-sided breast. The reason left-sided, not right-sided, is the left side just over the heart. So avoiding the heart's pretty important. Upper abdominal cancers as well, pancreas, gallbladder,
endometrial.
Some, and anything that avoids tissues behind them, that's really the concept. If you think of giving the radiotherapy and then you want it to stop, so nothing behind the cancer gets radiated. Fascinating. That was called the Bragg peak. It was invented by Lawrence Bragg. He was a physicist at Cambridge. Prize in 1921. It was the discovery was made really in 1902. And how he did it with, a battery and a few little toys on his desk, nothing very fancy.
I hope Cambridge has moved on since those times.
Yeah, a little bit.
Well, I mean, Peter Wilder said I was going from Holland to the Vitas clinic in Germany for my prostate, and he said, why is proton beam so much more expensive than other treatments?
It's very expensive to produce protons. Most systems have what's called a cyclotron, which accelerates the protons to the speed of light, or nearly the speed of light. They then go down a waveguide and hit a target and then come out. And most proton machines, the cheapest, the ones we've got, were on the cheaper end, the smaller ones, 15 million pounds, that sort of level. Expensive ones, 100 million pounds. So it's in that range. A conventional linear accelerator that delivers normal radiotherapy is 1.5 million. So a 10-fold cost of the machine. The building's bigger, the protection's bigger, and the training staff costs are higher a little bit, but it's mainly the cost of the machine that's high.
So give us all a clue then. So someone's got prostate cancer. How many treatments do they need? How much is it going to cost them if they ring you up?
What we've done now is reduce the number of treatments. Everybody in radiotherapy is shortening the courses. So we give 7 treatments for suitable patients. These are patients that have localized prostate cancer, no lymph nodes involved. 7 treatments, the total cost £32,000. The total cost for conventional, what's called VMAT radiotherapy, would be £15,000. So the difference is not huge. It's about double the cost with protons, basically.
And would it be the same for a left breast lady?
It would be about the same for a left breast lady. Everything
about brain tumor.
Brain, there we'd have to give longer treatments because the normal brain doesn't tolerate radiation so well. So we'd probably give, we would give 20 treatments, and that would cost a bit more, something in the 45 to 50,000 range.
Over what sort of time scale do you think it's all going to come down? Because
in the next 5 years, as it becomes commoner, and as the training programs are there.
Yeah.
Sorry.
Can I have the cucumber?
Right.
No. We're nearly, look, Alison, I can't have the cucumber. Someone wants to harvest the cucumber behind.
I turn everything off in the house.
All right, turn it off.
I keep telling you.
I just want to show the cucumber.
We're practical
For the
people.
grandchildren.
This is normal life. We don't pretend we're Michael Parkinson at any point.
Sorry about that.
Don't worry. Right, let's move on a little bit more. Amanda Roberts, I think she picked up on something in your past. Do you think diet has a role to play in cancer treatment?
This is a very profound question. We know diet significantly affects the incidence of cancer, of that there's no doubt. But does changing your diet when you have cancer make a difference to the outcome? And some people go to one extreme where you radically change your diet. You go strictly vegan, you avoid dairy, you avoid all sorts of things, and you may take supplements. Others don't believe it's the case. I don't think there's much evidence. There is a little evidence, but not much, that you reduce the rate of metastasis, which is really or local recurrence, which is really the problem one's trying to stop in following patients up. So I think the evidence is not really that strong. Definitely it prevents cancer, not so strong that it affects it. And Rob Thomas is interesting because he's got
I'll get you and Rob Thomas together when I come over, when COVID.
We should have a good ding dong about it.
Yes.
He presented It's a very interesting data ASCO, which is the...
I remember, hang on, I remember you writing something about the rainbow diet, and you said you didn't like it because you were frightened people would use it instead of treatment. But in fact, look, nowhere does it say that. I pick you up on the word outcome.
Right.
I don't think that one thing has an effect on someone's outcome. I think where Rob Thomas and I are is we can delay things. We're pretty sure using funny enough, he wrote all about polyphenols and I wrote all about polyphenols. This was about 6-7 years ago. We didn't know we were doing it.
Right.
And I'm really sure polyphenols can slow things down. Really sure.
Right.
And there's a very interesting lady called Dr. Young S. Kim, and she's at the National Cancer Institute, and she buys in all their cancer and nutrition studies. And she's adamant there's like half a dozen, I think it's 9 actually, bioactive compounds that can certainly slow down the return of cancer, if not prevent it.
Mm-hmm.
So I think it's
a fascinating area. Fascinating.
Well, so now you are also medical head of Buckingham University.
Yeah.
Yes.
So we set up a new medical school. It was great, fun experience.
So if someone like Rob Thomas and I approached you, would you be prepared to run courses for nurses and doctors where we provided them with game, set, and match on all the data there actually is? Because my patients are fed up with hearing oncologists saying, there's no research on this.
I know. The people we've got to get to are the oncologists, and there aren't that many in the UK. So there are 850 radiotherapy oncologists and about 500 medical oncologists. These are the people you've got to target. More and more women, 60% are women now. So things have changed. So how do you target them with this? Because and probably you do it through that, and everyone has to do what's called CPD, continuous professional development.
Yep.
So that would be the way to do it, to provide information so they can answer questions to patients. Because you're right, if the doctor doesn't know the answer, they tend to say, well, there's no research in this, there's no, like I was doing with toxins, for example, earlier on, I don't know. And
I didn't spot that.
No, there you go, I admit it. But I think not all my colleagues are quite so honest as I'm being here. But you're a very good father confessor, you see, Chris.
Yeah, that's right. Well, I mean, Rob Thomas actually went so far as he came down to London. We had a little chat about he was actually delaying the need for surgery by giving people broccoli, and tomatoes and exercise in Addenbrook's prostate. And he was putting it off by about 4 or 5 years. And the powers that be sort of said, no, you can't say that. You must actually prove it. So first of all, he was going to give this lot broccoli and tomatoes and exercise, and this lot none. And when he thought he can't do that, and then he said, no, you're going to make it as a pill. And he came down to see me because he needed to know who could make a pill. Because the second you want to make a pill, it's a drug, and no drugs company was going to help him.
Yeah.
And so that was the start of the problem. And from a glass of red wine, we were talking about polyphenols, I think, or something at the time. He decided to put curcumin and goodness knows what else in there. And he's done his clinical trial and everything. And I asked him the $64,000 question. Yeah, okay, so you bring down the PSA by 63% if you take POMI-T properly. Was it due to the cancer? Because that's always the interesting one for me. Does the cancer go down as well, or is it just the PSA? And he said, no, we've done the research too, and the cancer gets smaller.
Yeah, that's amazing. There's a lot of research to be done, and I think patients would be grateful for it. But the research charities they're not imaginative about it.
No, I think it's a quite tough one, I think, for us. So let's talk about people overall and the things you've learnt. If you had to give 3 little tips to patients, what would you say out of today?
The first thing is get full information about yourself. There's still I saw a patient on Friday who came for a second opinion, and her doctors refused to give her any information about herself, medical reports alone. No need to have a specially written referral letter, just copies of what's been sent in the past. We can quickly, any oncologist worth his salt can quickly build up the history from it, because often patients misunderstand. So that's number one, get the information. It's your information, it's you, insist on getting it. Secondly, go onto Google. It's difficult. If you get a younger member of the family to go with you, and look at the options. Just look at all the options out there. Become an expert in your own disease. A lot of the fear is from the words that are being used, rather than you understand it perfectly. The vocabulary is different from what you're used to. And then the third thing is, don't be afraid to go and get another opinion. And that's, I think, the big mistake. And you have to do it early. There's no point going to the end of it, having 3 lines of chemotherapy, 2 different types of radiotherapy, and then going for the second opinion. You have to do it before you start a treatment plan. So after the diagnosis is made, you have your biopsy, you have your imaging results. That's the time to get the second opinion before you start on any particular strategic path for your cancer. And by doing that, you have more chance. It may be that in most cases, the recommended treatment will be what you'll choose, and it's probably the best. But in some cases, there may be other options you don't know about. You've got to find those other options. And, it is your body, your cancer. So it's you that's got to sort it out. Don't think the NHS or any other healthcare system is necessarily going to sort it out. It can be used and harnessed, but you're the one that has to drive this. And read about it everywhere.
Thank you for that. Thank you. I promise all my regular viewers that I did not tell him to say those 3 things. We hadn't even.
And I should say, read Cancer Active when it comes up.
I say much the same things. Look, thank you. It's been really enjoyable to talk to you.
I'm sorry about the backdrops.
No, don't worry.
Sunday mornings.
We will. I'm tempted to leave your cucumber in, actually.
Do so. There's my cucumber.
One of these moments, I think, in video. Anyway, look, thank you very, very much.
Okay.
I've learned a lot, and I'm sure the viewers have too. And perhaps one day we'll get you back on the show next year or something like that. It's been very, very kind of you.
Thank you very much. And I look forward to seeing you in London.
Yes, well, when I've had a jab, we have a bit of a problem with jabs at the moment in Thailand, because the AstraZeneca thing's not working over here, and I'm not going to have Sinovac, I'm sorry. No. So I've got to have some jabs, and then I can come back. But my house is actually in the south of France, so it's all a bit convoluted for me to come back and see the kids, get the car, drive to south of France.
I know.
So hey, life actually gets harder as you get older. I don't know what it is. All right, all the very best to you. Happy Sunday.
See you then. Bye.
Bye.